So I want to be clear, I don't feel like I have any specialized expertise in responding to children who are affected by a suicide. We are in the business of responding to people who are distressed about a range of traumas, including violent and sudden death. But when Dr. Rice Neerson asks you to do something, what can you do? You have to say yes. So I just do want to say, I don't, in my own direct experience, and I want to reflect a little bit later about some of my clinical experiences, I have not found working with when the trauma is suicide that it is all that different than the other traumas that we deal with. Every trauma, the individual person always has their own unique response in terms of what it is that sticks with them or bothers them or the questions they ask themselves. So we don't our little lane, we don't differentiate types of traumas that much anymore. And partly that's because, everyone has them. I just want to make that point. Everyone is exposed to trauma. It's ubiquitous in the general population. Kids, about 80% of them by the time they're 18. Same thing with adults. And many of them have had more than one experience. So back in the day, our whole field developed with the little lanes, where there were the people who did this type of trauma, the sexual abuse and the physical abuse and the witnessing domestic violence and the violent and sudden death and the disasters and this. And I think that's inevitable when you start developing a field, and I'm that old, because there wasn't actually that much of a field when I got into it by accident. But I think that overall in the trauma world, we've come to know that trauma is widespread. Lots of people have more than one, and then you can pile right on top of those. Everybody familiar with the ACEs? Okay, so in the original ACEs study, there are 3 or 4 traumas. There are about 10 different bad things that can happen, and 3 or 4 of them are traumas, meaning threat-related events, and the others are other bad things that can happen to kids. And everybody wants to add things into it now, I might add, because ACEs doesn't capture traumas that don't happen in the family. Rape, witnessing violence, accidents, it's not in there. But the bottom line is, I think at this stage of the game, what we have learned about trauma is it's common. And it's the piling up of traumas and adversities that really leads to the significant problems. I mean, we humans wouldn't have been around that long if traumatic events were knocking us down back in the day, and everybody had to go to therapy when they were living in on the plains. It couldn't be true. Humans are, and I was so happy to hear they're talking about the resilience. Humans are built to manage stress, and sometimes it just overtakes people because there's too much of it or it's a particular experience. So we tend to conceptualize the trauma as, really what's the one that's bothering you and how much of it have you got? And I do think in some ways that's a little bit of a parallel, because I don't know really that much about grief per se, but seems to me everyone's going to experience it. Everybody's going to have someone they care about die. It's a part of the life experience, like it turns out, sadly, trauma and other adversities are as well. And most people make their way through it on their own resources and their own supports and all of that. And I think that's a super important framework to hold. Now, I'm in the therapy business, so that's what I do, that's what our clinic does. And if we identify a child or an adult as having a level of distress, post-traumatic stress, that really warrants or where they would benefit by a formal therapy, then that's what we would do. And just to remind people that trauma and adversities account for about 45% of childhood onset clinical disorders of the whole range, not just post-traumatic stress, and over a third of adolescent onset. So trauma and adversities you start piling those things up, and that's going to can lead to kids developing clinical problems. But the problems are not always trauma-specific. So for a trauma-specific therapy, that's what we want to find out. So at our clinic, the way we would do that, and just by the way, I think our framework is not everyone needs therapy, but pretty much everyone could benefit by validation, normalization, and support. And that's one of the main things we've been teaching, because we do a lot of teaching for public mental health. And we want people to routinely ask kids about these experiences and then give them validation and support and normalization, whether or not they have a trauma-specific disorder. We don't want it to be nothing, and we don't want it to be everything. And I think it's an odd thing how we've somewhat conflated having a bad experience with, well, if it was a bad experience, you would have to be psychiatrically ill, or you have to have persisting distress. And I don't think that's done any favors for people. And I just saw a fellow this week, and it wasn't a suicide or a traumatic death, but he was like, it's like I'm trapped. If this really big thing happened, he was shot. Big thing happened, and it really has changed my life, but I don't think I'm really have a mental health disorder. But it's tricky, because if you don't show it, you often won't get the validation, or you have to have therapy or a mental health disorder. And I'm against that. I think that we should acknowledge these are widespread experiences, and everyone benefits by an acknowledgement. And opening the door, that's the big thing we're trying to do in public mental health. Open the door. It's already happened to them. It's not news to the patient that they've experienced these things. It's news to you. And if you can show every single client that you see that you've heard about it, that you're interested in it, and you can handle it, you will learn a lot of things about your clients that you might not have known. So we're not really so much into the waiting till people are ready business. We're into the invite people to share, and people will tell you what they want to, or what if they don't want to, they won't. But that you want to respond in a way, and I appreciate everybody talking about it. Let's not mince words, beat around the bush, refer to it as opposed to that, the suicide or the crime or the sexual assault. So our strategy on this is, if people come to us, and we probably in our clinic will tend to see more people coming acutely, like they're worried about their kid because this thing happened to them. And not all of them are going to actually need or require therapy. So we just do a very straightforward assessment. None of these long, complicated batteries of anything. But every patient who comes to our clinic, they get a tablet when they check in, and they complete a post-traumatic stress measure, and we ask the parents what they think about the kid. So I can look right up on my computer and see what traumas this kid says happened to them and what their level of post-traumatic stress symptoms is before I've ever met them. And I can tell you right now that we have never had a single instance where people fell to the floor in our waiting area because they were asked these questions. People don't mind telling you. You know what they do mind? That you don't talk to them about it. I just can't stand the thing when we're going around screening people for things and then we just put it in the drawer or in the chart and we never have a conversation. So we would always start with the conversation, and we're pretty down and dirty about talking very explicitly about it. Tell me about that. Well, and we don't really care about facts in the trauma biz. We care about perceptions, feelings, symptoms. So that's what we're most interested in learning from people. Now, if it looks like somebody could benefit by or needs treatment, well, we have a treatment in our trauma world. There are a variety of them, but they're variations on the trauma-specific therapy, CBT-based, and there's pretty good evidence they work for violent death, traumatic reactions following death. And so that's the framework we use. We don't have specific treatments for every different type of trauma. And I would say they work really quite well for the whole range. And here's the diff for taking a trauma-specific type of treatment, and where it's violent death, is you have to add on some part to the treatment that directly addresses the grief part of it. So you guys probably all are pretty familiar with the standard trauma-specific evidence-based type approaches. They have two general components. One is responding to intrusions, so images, memories that have sensory content and are very disturbing to people. So the treatment for that generally is imaginal exposure, meaning facing up to your memories, learning you can tolerate actually remembering, not so you don't have to shut it down or avoid. That process allows people to learn, I can handle thinking about it. And we generally would, most of the models say, do that first, something like that first, because it's pretty hard for patients to participate in the second part, which is it's the meaning making. So what does it mean that this happened to me? Why me? Why did this happen? What does it mean about me? Am I different? Am I changed? How my outlook on the world changed? So exposure can happen in many ways. It doesn't have to be in a formal type of prolonged exposure way, but it really means helping patients learn to think about what happened without a lot of distress and without using a lot of avoidance. Now, let me be clear. I'm talking about people who have a mental health disorder that we're going to treat. I'm not talking about every person. It's only when they really need this active intervention that we would do this. A lot of treatments that are evidence-based would refer to it, the making meaning part, as develop a trauma narrative. And really what that comes down to is helping someone create the story they're going to tell themselves about this traumatic event, what it means, and creating in a structured way, going from the past to the future. And that's the goal of all trauma treatment. Rather than focusing on the bad thing that happened in the past, to be able to say, that's a thing that happened to me, it isn't me, it affected me, but it's not defining me, and I can have a life going forward, just to oversimplify the basics of it. So that's the core of really all the proven treatments for traumatic stress. So the different thing that we bring into it when it's a violent death, not specifically just suicide, but of other sudden and violent deaths. That's what the criteria that is required for getting PTSD. It can't be now they allow for sudden. So like if a kid is sitting at the dinner table and the dad keels over with a heart attack, that would count. But a parent who's had a long chronic illness, that would be more in the grief lane, because it's not so much about memories of how a person died affecting you and persisting. It's really more about the loss part of it. So some of the elements for the traumatic grief components, and Cohen, Manarino, and Deblinger, they are the premier people in having developed the best research and best supported treatment for trauma and traumatic grief. They have a lot of neat suggestions and ideas for what you bring into it when it's a traumatic death. They've done a lot of work, and they had a whole project in New York after 9/11, and so they really are super well grounded in all of this. And Alison Saloom's, she's also a very strong, good trauma and grief person. She's in both worlds. So those people are in my world. I don't know as much about the ways that you might generically be helping kids and families, but I did get myself a consultation on grief before I came here, because I was a little worried about maybe stepping off into the abyss. So I called a friend of mine, it's Christine Linehan, who happens to be, I met her because she's the wife of David Finkelhor, who's one of the most famous researchers on child victimization in our field, but she's a grief person. That's her practice. So I did call her up the other day and said, could I get a consult to make sure I'm not off base here? And she recommended those books and said that they're considered to be. So I just thought I'd slap them up under my resources. And then the National Child Traumatic Stress Network, they have a handout for everything. So you name it, they've got it. If you are on the hunt for tips for caregivers or what to say to kids or how to talk to them about traumatic events, they're a very good resource. They really try to be available to the world. Now, one of the neat things about Cohen, Manarino, and Deblinger's particular model, and I was really listening to you guys talking, is that it's a family intervention. It is not an individual intervention for kids. All the studies, and they have a lot of them, it's always tested with a family component. It's really actually as tested, half kid and half parent time in the therapy. Because part of it is enhancing the parent's sensitivity and awareness to the kid's experience, but it has a very neat component that when done right, meaning you got to prepare for it. It's called the conjoint share. Well, it's a structured session or a couple sessions where the child is helped to share their narrative, their trauma narrative, with the parent, so the parent can really hear from the child what it was like to be them in this experience, and the parent is coached before the structured conjoint sessions to validate, acknowledge, and tolerate. So I think it's getting at what you guys were talking about. We want kids to have people in their lives that they could turn to and talk to about what happened. We don't want to be the special person. We're coming, we're going. And if they've children and parents have never had a chance to talk about it, what are the chances they're going to do it later on? So we create that in the delivery of the trauma-focused CBT. And how we think about it is, well, if 3 years from now, they're at school and there's a big presentation on trauma, or violent death, or suicide, or whatever, we want the kid to be able to come home and say, Dad, I had a little bit of a hard day today because the school talked about this. I started thinking about what happened, and I tried to use those coping skills that I learned in therapy. But I just wanted to let you know, we're trying to set the stage for the rest of their lives, that they have a place to go, because you don't ever really get over a traumatic death, in my experience. You learn how to live with it the best you can. So we want to think ahead for kids. So as you can see, this type of thing, now this is a structured, evidence-based type of treatment. Yeah, there's a beginning and there's an end. It's not an open-ended type of therapy. And we have a goal, which is basically to get people's post-traumatic stress and depression down. And I can tell you it works super well. I've done it, for God knows how long I've been doing this. I hate to even start thinking about it. It's kind of crazy. But it's the great thing about doing trauma work, I can tell you. A lot of people always say, how can you stand that? That's so horrible. And I'm like, are you kidding? I don't have anything to do with the trauma. Everything I'm doing is helping someone do better and live better with this terrible thing that's happened to them now. How could you not feel honored by getting to be part of that journey? I don't find it distressing that at all. I find it, inspiring, because I've seen humans go through the worst possible things and come out just unbelievable. But it's a very directive kind of approach. So it's a little bit different from what you're talking about, because we're going to the heart of the matter. We're not waiting until someone's ready, because most of our patients, they would not be ready, because there's a good reason why people avoid. In the beginning, thinking about it is stressful. So it's pretty structured. So I was trying to reflect on a few cases I've had and a few things that have popped up for me that have been somewhat different about suicide. And I have had, and we have at our clinic, we periodically, it's not like a big part of our book of work, but kids who have reported abuse and then the offender has committed suicide. Now, the first time I ran into that years ago, I thought, oh my gosh, this is terrible. They'll be devastated and everything like that. And I'm going to say I haven't found that to be totally true. Obviously, it's difficult and shocking and all of that. But my experience is it's been more ambivalence about it, to be honest. And I think that's often a situation with suicide is ambivalence. That's, I would say clinically, that's what's jumped out at me. And I think about this young girl I saw this past year, and she had been molested for a long time. She came forward, and then the guy killed himself while he was awaiting trial. And of course, she was the smartest person I've ever met, I have to say. You got to be on your toes with her. But she just said, don't say it. It is my fault. I know you're going to try to tell me it isn't. If I hadn't reported it, this wouldn't have happened. I said, okay, that's true. But she said, but I don't regret telling, because the reason I told was to protect other kids, my younger cousins. And I still think that was very much the right thing to do, and it's on him that that's what he ended up doing. So I can say that's actually been a little bit more my experience with these situations is, yes, it's horrible, but it's also a little bit of a relief because it's resolved. And the relationship will be in their head, not in their actual real life. And I've had a couple of other experiences like that, but not so much with an offender, but where a parent who has had a lot of problems for a long time, suicidal, other kinds of problems, and it's spilled over onto their kids, and eventually there's been a suicide, and again, the ambivalence. So where the part of it is so sad and hard, and there's the part also, I'm hoping they're in a better place, is kind of what I have heard. So I just wanted to throw, I haven't run across stigma. I know that's what Christine told me. Stigma is a feature, but I haven't really noticed that. But I figure that's probably because the people who would come to us seeking a treatment, that's not a barrier because they're there. So we're not really talking about. So that's kind of in a nutshell what we would do in our structured trauma-focused treatment. But there are plenty of people who, they want what you guys are doing. They want ongoing support and other people who, and that was the other thing Christine told me, group support. That's a very welcomed for people. So I always feel so dang lucky in our town because we've got so many places we can refer people. So we don't have to say, oh my gosh, we have to take that on too. So if somebody wanted, we always tell people, if you're interested, here are some resources. If it's a violent death, I'm going to Dr. Reinerson's shop. I don't think I would think of you guys first off for that, although I was very interested to hear about it. But if what people are looking for is help with the grief process, which for everybody's going to work its way out its own way, we turn to the Healing Center and the Safe Crossings. So I feel very fortunate to be in our town where you've got people who do everything. So I did tell a little story to Jen when I got here about, the beauty of it all. Every once in a while, somebody who's really looking for the PT clinic calls my direct line. I don't know who it is who keeps giving people my direct line. But when I pick up the phone and they say, I'm trying to confirm my appointment, I'm like, what appointment? And I usually will say something like, well, I don't think it's probably our clinic that you're looking for. We're the traumatic stress clinic. So a couple of weeks ago, some guy called, and I said, I think you're looking for the PT clinic. I'm happy to give you the number. And he said, well, I think I might need some traumatic stress help. My mother died, and it wasn't really so traumatic, but I just can't really get past it, and I'd really like to get some help. And I said, well, have I got a deal for you? So sent him to Jen's, and she thinks he might have showed up. So thank you very much.